Thank you very much for this nice introduction, and it's a pleasure for me to give a presentation on home NIV and stable COPD. And I think these questions are important, how and why. So I'd like to start with a historical remark. And if we go back to 1984, so nearly 35 years ago, this is a study where negative pressure and positive pressure ventilation has been applied in patients with COPD. And you can see that during following up, there was an improvement in PaCO2, an improvement in PI max, which is the maximal inspiratory mouth pressure, an improvement in the dyspnea scores, and a reduction in hospital admission rates. And from that data, it was concluded that the capacity of mechanical ventilation to sustain normal capnia during spontaneous breathing would reflect an improvement in the respiratory muscle function. This was 35 years ago, just to remember. And this is another study published very, very long ago, 1992, having a completely different approach. They did apply non-invasive ventilation in COPD purely overnight, and they had been able to show that there had been significant improvements in gas exchange, but also in sleep quality. And from this data, it was concluded that nasal intermittent positive pressure ventilation could be effectively used in the home environment, particularly during sleep in selected patients with COPD. And based on this, it was concluded that we should have actually two different rationales for the application of non-invasive ventilation in COPD. And this was concluded on an international conference or consensus conference from 1998. And these are the two hypotheses. One is the muscle hypothesis, saying that non-invasive ventilation is aimed at resting chronically fatigued respiratory muscles. And in comparison to that, the sleep hypothesis means that non-invasive ventilation is actually not aimed at improving gas exchange during subsequent spontaneous breathing, but is primarily aimed at preventing sleep disordered breathing and aimed at improving sleep quality. So actually two completely different approaches of how non-invasive ventilation should be applied. And my personal view on that is that this is the reason for why we had so many different attitudes towards non-invasive ventilation to be used in COPD patients during the last 1 or 2 decades. This is also old data published in '95 showing that the prognosis in COPD is worse compared to patients with pure restrictive diseases, that is post-tuberculosis or kyphoscoliosis or neuromuscular disorders. And this is actually clear as COPD is also a disease affecting the lungs, the airways, and has significant and important comorbidities. So, however, the question still remained if non-invasive ventilation is really suitable to be applied in patients with COPD. And this is the first meta-analysis summarizing 4 of the recent, of the previous randomized controlled trials, showing actually that non-invasive ventilation is not as efficient in improving physiological parameters such as sleep efficiency, gas exchange as displayed by CO2 here, maximal inspiratory mouth occlusion pressures, or lung function testing. So actually results that times had been purely negative. And the reason for that was that quite low inspiratory pressures had been applied. So in the first study, 10/2, 15/2, 18/2, and 12 to 14/4 for the inspiratory and the expiratory pressures as well. And 2 subsequent studies have also looked at the outcome when non-invasive ventilation has been added to long-term oxygen treatment compared to classical treatment, which was long-term oxygen treatment alone. And again, the inspiratory pressures have been quite low, 12 and 14 centimeters of water. And predictably, from what has been shown before, the gas exchange was not effective in a positive manner. So there was no improvement in elevated PaCO2 values. And actually, it is predictable to say that if you don't change physiology, you cannot improve survival, which was also evidenced by these 2 of the trials. Well, And this is a more recent study, however, published now 10 years ago, the Australian study. And again, non-invasive ventilation was applied overnight. And when I will just to show you that when looking at the title, nocturnal non-invasive nasal ventilation, it becomes clear that these researchers were on the part of the sleep hypothesis. So sleep doctors and pneumologists did approach the field of non-invasive ventilation in COPD quite differently. And again, low inspiratory pressures had been used. The IPAP was in the range of 12 to 13 centimeters of water. And there wasn't, it's interesting to see that there was a small survival benefit, but it was clearly reported that this was reportedly at the cost of a reduced quality of life. But this, however, this conclusion is crucial because if patients do receive non-invasive ventilation, but non-invasive ventilation is not capable of improving the physiology, doesn't make anything in a physiological thinking, then actually, of course, the mask is ineffective and would produce side effects as patients have to wear something which is cumbersome. And quality of life, by the way, was not specifically measured by specific instruments, but was generally measured by the SF-36. I will come to this point later on. However, this was published in 2002, and this is actually the first study we did on this topic. Now more than 15, 17 years old. And the idea was just to show and just to investigate if it's theoretically feasible to bring down the CO2 during daytime spontaneous breathing. So these patients had been severely hypercapnic, 60 millimeters of mercury over daytime, and it took about 5 to 9 days to bring down the CO2 to nearly 40 centimeters to 40 millimeters of mercury. So, and if you look at the settings, the mean inspiratory pressure was 30 centimeters of water, and patients did receive pure controlled forms of ventilation with a respiratory rate of 23. Of course, this is severe, and this is suggested to be not practical for the vast majority of patients. This was a proof of concept study just to show that it is feasible to bring down the COPD in contrast from what has been published before. And this is the, I would say the original description of what is called high intensity non-invasive positive pressure ventilation, published in 2009. So this is a description of 73 patients receiving non-invasive ventilation with the physiological aim to get a maximal reduction in PaCO2. For that purpose, the inspiratory pressures range around 28 centimeters of water. However, there was a huge variety amongst the different people. In some patients, pressures were not necessary, higher pressures were not as necessary, but of course, higher pressures are not feasible in all of the patients. In contrast, however, there are some patients requiring even higher pressures, higher than 30 or 35 millimeters of mercury. The respiratory rate ranging between 10 and 26. This is also a huge span actually, but I'd like to draw attention specifically on the mean respiratory rate, which was 21 per minute, and we will see how this is translated into the upcoming research. Well, and this is a paper, I don't know if you are familiar with the journal Breathe, which is an educational journal of the European Respiratory Society. So a very practical one. And I was also asked to address the topic on how to practically perform high intensity NIV. So first of all, I'd like to give a definition on what high intensity NIV actually is. And it is, first of all, originally described for patients with COPD. Of course, this would also translate for patients with different diseases, but originally it's described for COPD. And it is long-term non-invasive ventilation, physiologically aimed at achieving normal capnia, or if this is not achievable, the lowest possible PaCO2 values using high ventilator settings as maximally tolerated by the patients or necessary. So in other words, high intensity is more or less an attitude, a physiological attitude to positively affect respiratory muscles and the respiratory pump. It's not defined by certain pressure levels. So if you are successful with inspiratory pressures which are lower than 20 centimeters of water in getting down the CO2, it would also mean high intensity NIV. And if you use different approaches aimed at improving gas exchange, this in the end would also would also mean that it is high intensity NIV. Typically, we use home care devices in the home environment, and typically pressure limited non-invasive ventilation is preferentially used because we know that we have fewer gastrointestinal side effects compared to volume limited NIV. However, volume limited NIV is also feasible in the approach of high intensity NIV, and we use the assist control mode. And in that publication, I have also given an overview on how to practically use high intensity NIV. And it's important to note that non-invasive ventilation in this approach at the very beginning is used at daytime first. So don't start controlled ventilation and don't start high pressures with a patient during the first night. Sometimes it takes only one day to get patients acclimatized to non-invasive ventilation, that approach. However, sometimes it takes days or even weeks. So don't give up too early. Daytime acclimatization is the maximal and the first aim for high intensity NIV. Of course, we do start with assisted forms of ventilation using low pressures. And the next step would be that inspiratory positive airway pressures are carefully increased in a stepwise approach. Of course, this needs to be done in accordance with a patient's tolerance. Again, some patients do tolerate a rapid increase in the pressures within a couple of hours, and in some patients, more days or weeks are needed to get patients acclimatized to higher pressures. So if a higher pressure is achieved in a COPD patients, the next step would be to increase the respiratory rate. And this is an important issue because if the respiratory rate is too high, the patient would be at risk for dynamic hyperinflation, of course. And therefore, the respiratory rate should be set just beyond the spontaneous respiratory rate. Typically, it's around 18 or 20. And of course, we need to make sure that respiratory rates are not lower overnight. And we need to make sure that hyperinflation and dynamic hyperinflation is avoided over nocturnal treatment. So eventually, this might be changed a little bit when switching from pure daytime to nocturnal application. And of course, in the end, non-invasive ventilation should be applied overnight if patients are fully acclimatized. So once daytime tolerance is acceptable, then we go for nocturnal non-invasive ventilation. And then ventilator settings are adjusted according to subjective tolerance and according to nocturnal monitoring of blood gases. And of course, subjective tolerance is severely important and is, of course, much more important than a certain pressure level. So sometimes, and I think I have just pointed out this issue, but it's important to say it again, sometimes patients do not tolerate pure high intensity NIV. But if you send patients home, and if patients are sent back to hospital a couple of weeks later on, patients typically they are acclimatized and they would tolerate higher pressures in a better way. So try again to increase the pressures in case of patients already established on home NIV. Well, it is of course interesting to ask if it's the pressure component or if it's the backup rate. I displayed here, BUR is the backup rate. And this is a quite interesting trial from the British group. Patrick Murphy and Nick Hart did this trial, randomizing patients in a crossover setting to receive high pressure NIV and high pressure plus high frequency NIV, which is actually the classical approach of high intensity NIV. And you can see, and it was quite happy also for me to see that not only people in Germany that time used pressures in the range of 25 to 30 centimeters of water, but that also other researchers from other countries did. So you can see that in this cohort, patients had backup rates around 16, 16, 12, 18, 18, 18, 16, 14, and 12 breaths per minute. And this is probably not pure high intensity NIV in terms of the definition I have raised before. And this is important for the interpretation of the findings, while of course the backup rates around 6 this is pure assisted ventilation. The other issue with that study, however, is that only 6 patients had been randomized to receive pressure support ventilation first and pressure controlled ventilation first, and there had been some patients lost for follow-up. So eventually, only 7 patients remained with all measurements completed, and this is important for the interpretation of the findings. So basically, what they found was that there was actually no benefit when high pressures had been combined with higher respiratory rates compared to high pressure ventilation purely. You can see that the CO2 values is displayed here, or the compliance, the overnight adherence to treatment, and also the SRI summary score, that is health-related quality of life, were unchanged with regard to the 2 groups. However, as pointed out before, some patients still had been hypercapnic, and a further increase in the respiratory rate or the pressures could have eventually resulted in a further improvement in the PaCO2. And 7 patients in the end is probably a very small group. So clear conclusions or clear recommendations cannot be given so far with regard to this question, if it's actually the pressure component or if a higher respiratory rate is really necessary. So in regard to a controlled ventilation, my personal experience is that if patients have controlled forms of ventilation, but if the respiratory rate is set just beyond the spontaneous respiratory rate, so dynamic hyperinflation is avoided, patients feel quite comfortable because they can relax themselves. So the machine does most of the work, and patients can, let's say, the diaphragm can sit on the sofa, I would say. However, this needs further investigation to give a more clear recommendation on that. Another interesting study I just to present is that actually the prognosis of non-invasive ventilation and chronic respiratory failure and COPD is clearly dependent on the body weight. So obese patients had, in this study, a reportedly better prognosis compared to patients who had been not obese. And it's also interesting that they also covered these findings and combined these findings with the compliance, that is the duration of the application of non-invasive ventilation per day. And you can see that if you look at obese and non-obese patients together, that there is an appearance of a U shape, saying that the risk for death or hospital readmission is higher if patients do not use the ventilator, or if patients are severely sick and they use non-invasive ventilation for more than 8, 9, or 10 hours a day. And these results become even more evident if we compare the groups of obese and non-obese COPD patients. Here, actually, there's no clear effect, but in regard to the obese patients, patients who require non-invasive ventilation and who use it for 5 to 6 hours a night have the best prognosis. And of course, patients require longer application durations, are more severely sick, and they do have a worse prognosis in terms of readmission, hospital readmission, and death. So the same research also used a Tele Monitoring, and I know that many people today are highly interested in Tele Monitoring. Of course, we have only, in the international literature, we do have only very, very few data. So it's clear that we cannot give any strong conclusions on Tele Monitoring, but we do have some interesting findings. And this is a study looking at exacerbation rates and looking at the parameters provided by the ventilator in the capability of predicting an exacerbation. So this is a questionnaire showing that patients is about to exacerbate right here. And you can see that there was at least a trend for a longer duration of non-invasive ventilation per day. But it's even more interesting to see that the respiratory rate was about to increase from 16 to 18 or nearly 20 in the days preceding the real exacerbation. And that was also true for the percent of respiratory cycles triggered by the patient. So there was more need for mechanical support the days preceding exacerbation. This could be the future, that we get information from the ventilator, from the built-in softwares, saying or providing evidence that something is about to happen or going to occur. Well, going back to high intensity NIV, this is a real-life study. So published also now 14 years ago with an inspiratory pressure of 28 centimeters of water, and again a respiratory rate which is pure high intensity NIV. And comparing to what has been published before, we were able to show that there's a significant improvement in the physiology. That is PaCO2 with a decrease of 7 millimeters of mercury. And this was true for the subsequent spontaneous breathing period. So not during the application of non-invasive ventilation, during subsequent spontaneous breathing. And there had also been improvements in oxygenation, and also in that trial, improvements in FEV1 and lung function parameters. And the 2-year survival rate was reportedly 86%, thus showing that these patients had also that they used non-invasive ventilation in that approach. And it was with that publication, I always keep telling the story of Thomas Petty, who wrote a letter to the editor. And I don't know if you know Tom Petty. Actually, I would say he's the inventor of long-term oxygen treatment for COPD patients. And he wrote that actually non-invasive ventilation is not required in COPD patients at all. And he said that the increased level of CO2 would reflect the wisdom of the nature. And we know from long-term oxygen treatment that the prognosis is improved, and that this is particularly true for patients who have or who would experience a certain amount of an increase in PaCO2. So actually CO2 could eventually be good for you, but we responded to that letter by saying, of course it would reflect the wisdom of the nature, but we do not treat the CO2, but we do treat the respiratory pump, and this is reflected by CO2. And we know that we have now clear evidence, and I will come to this later on, that if you treat patients, if you treat the respiratory pump, and if you do not exclusively look at the sleep hypothesis, but also at the respiratory muscles hypothesis and at the respiratory pump hypothesis, then eventually physiological parameters as well as outcome are likely to be improved. Well, and this is also evidence for the differences of the ventilator approaches. This is a crossover trial, a randomized crossover trial comparing high and low intensity NIV. So inspiratory pressures were nearly doubled, and patients received controlled and versus assisted forms of ventilation. Patients had been severely hypercapnic overnight, and you can see that from baseline, patients randomized to receive high intensity first had a significant drop in the PaCO2 overnight. And once patients had been switched from high to low intensity NIV, the PaCO2 increased again. And conversely, the opposite turned out to be true for patients receiving low intensity NIV first. So overnight, there is a certain effect in CO2 reduction, but the huge part of CO2 reduction occurs only if patients are later on switched from low to high intensity NIV. So actually this was a physiological study with a primary outcome of nocturnal PaCO2. And you can see that the mean treatment effect between the two approaches was nearly 10 millimeters of mercury in favor of high intensity NIV. So people typically keep saying that patients do not tolerate higher pressures. And this study, interestingly, was also capable of showing the opposite, saying that the compliance is improved if CO2 is reduced. So patients in the high intensity group spent an additional 3.6 hours on non-invasive ventilation. So 3.6 plus the time used for non-invasive ventilation as spent during low intensity NIV. And the studies showed also that this is clearly conceivable that patients are more compliant with the higher pressures because high intensity was shown to be capable of improving dyspnea, of improving quality of life as measured by the SRI, and also of improving FEV1 in that trial at least, compared to low intensity NIV. Not shown in this slide here, but I can also tell you that we also looked at leakages and leaks amount when comparing high and low intensity NIV. And of course, if you increase the pressure amounts and the respiratory rates, you also increase the leakages occurring overnight. And one question from that trial as raised by the reviewers was, how did this translate into sleep quality? And unfortunately, we could not answer this question because we did not measure polysomnographic things overnight. And that was the reason for us to do a very similar study, published a year or 2 years later, exactly on the same topic, but now more clinically looking also at sleep quality. And this study, first of all, again, this was a crossover randomized trial. This study again confirmed the findings on CO2 with a clear favor of high intensity NIV in terms of the capability to get down the CO2. But the two approaches were also in line with a well-preserved sleep quality. So patients had deep sleep and they also had REM sleep, and there was no disimprovement in regard of high intensity NIV, even though, as pointed out before, leakages were reportedly increased in case of high intensity NIV being used. Well, and there's also an interesting study from Turkey. Even though the pressure settings were not as high, this study again showed that if more patients do receive ST modes, and if pressures are at least a little bit higher than in the other group, then patients have a higher compliance rate. So in that study, the IPAP level was positively correlated to the compliance of NIV, again providing evidence that higher pressures are not associated with a worse compliance, but in the end with a better acceptance, if you, of course, take time with a patient in hospital to get patients acclimatized, as already pointed out before. And there's also evidence from a more recent meta-analysis showing that if you use higher IPAP levels, and if you have a better compliance and higher baseline values, this would at least seem to improve the physiology. So summarizing this meta-analysis, we need to go for inspiratory pressures higher than 18 centimeters of water. And we also need to aim for a compliance lasting at least 5 hours a night. And of course, if the higher the CO2, the better the effect of non-invasive ventilation on the CO2. Another question for us was, what are the best techniques for the application of non-invasive ventilation in COPD? And the question is, if we had been successful clinically with high intensity NIV, was there further room for improvements if we would switch patients from established high intensity NIV to target volume ventilation? So for high intensity NIV, patients did receive pressures ranging around 26 centimeters of water, and patients had been then switched to target volume NIV, and for that purpose, the inspiratory pressures were allowed to go down and to go up, aimed at achieving the preset target volume. And you can see that in real life, we did measure this pneumotachographically. You can see that the pressure ranged from 21 to up to 35 centimeters of water. In the end, however, in regard to transcutaneously measured CO2 measurements, there were no significant differences in regard to the two groups. So we can conclude that if you take time and if you look at the patient carefully and if you establish high intensity NIV, an addition of target volume settings is actually not necessary globally, overall. However, if you take a closer look at individual values, you can see how broad the range is. So there are some patients significantly deteriorating when getting switched from established high intensity NIV to target volume ventilation. But the other way might also become true, that there are some patients quite sufficiently acclimatized to non-invasive ventilation, but remaining hypercapnic overnight. And in these patients, you can try individually different approaches. Again, this would also be the classical approach of high intensity NIV, which is, as pointed out before, purely physiologically defined. So if you're not successful in terms of blood gases or in terms of subjective comfort or any other reason, then of course go for different approaches also technically, try different masks, use volume preset ventilation instead of pressure preset ventilation, or also try target volume ventilation. However, overall, there's no reason to globally recommend target volume ventilation based on this trial, and we have also other studies showing very similar results, as also sleep quality was reportedly comparable. So there were no differences in sleep quality, no differences in nocturnal gas exchange overall, lung function testing, exercise tolerance, but also quality of life and side effects. But on an individual approach, it might be interesting to offer patient this nice technique. So another question is also important in regard to the interface. And if we go back to 2005, in reality, this data dates back to 2001, by the way, nearly 20 years. So the question, what interfaces are being used in Europe? And if you go back to nearly 20 years ago, you can see that the most patients did receive nasal masks. In neuromuscular patients, also invasive ventilation was used in 10 to 20% of patients, but in patients with lung disease, so most importantly COPD, the vast majority of patients did receive nasal masks. However, this has now been completely changed. And this is an international survey we did together with the different groups around Europe. And you can see that around 1/3 of patients in Europe only did receive nasal masks. Or more than 30%, 40% did receive oral nasal masks, and some patients did receive full face masks. And we have also an approach of rotationally using both nasal and oral nasal masks. And we did also some more recent data on this question, looking at our COPD cohort, at our own patients. So this is a monocentric study, but 172 patients were screened for eligibility. And you can see that now the group of patients receiving full face mask and this group was around 80%. So 4 of 5 patients in our cohort do receive full face mask. And you would now ask me, what is the reason for changing the attitude? And my answer is, I don't know. This is how things happen. We do not have clear evidence for this approach. Maybe we can say that in accordance to that study, that patients having massively high pressures, or patients who are older than 70 years of age, or patients who are more or less cachectic in a clinical individual setting, are more frequently established on high intensity NIV using full face masks, while patients who are super obese or have psychiatric comorbidities would eventually end up more frequently with nasal masks. Another A really important issue is quality of life, as pointed out before. And it's also a miracle why many studies have used instruments which are not specific for respiratory failure and non-invasive ventilation or any other specific techniques used for the treatment of chronic respiratory failure. And that was the reason for why we did invent this questionnaire called the Severe Respiratory Insufficiency Questionnaire, the so-called SRI. And this is a multidimensional instrument which provides 7 subscales: respiratory complaints, social functioning, well-being, anxiety, social relationships, attendance symptoms and sleep, and physical functioning. And according to statistical analysis, these subscales can be summarized to one summary scale. You can also see that this questionnaire is well validated and has been used in numerous trials, and has also been translated into several questions. Many of these translations have also been validated so far, and you can go to the homepage of the German Respiratory Society. You can use this link here, and you can download more or less all of these different questionnaires. So you can also have your language. We have also a Norwegian one, we have a Danish one, we have a Swedish one you can use for your clinical purposes and also for scientific purposes. And it's important to note that it is free of charge if you use it for clinical and scientific purposes purely. Well, if you look at studies, a completely different picture turns out to be true, saying that if you use non-invasive ventilation and if you assess health-related quality of life prospectively, then you are able to discover an enormous improvement in health-related quality of life, as evidenced by this significant questionnaire, which was the SRI. I mean, this was also true for the generic questionnaire, but you can clearly see the difference. If you do not ask specifically, you would not get the whole picture. So it's absolutely clear that in case of specific treatment interventions being assessed in a scientific approach, we need also to use specific instruments. And you might say, of course, not only COPD, but also restrictive and neuromuscular and obese patients had been analyzed in this study. But if directly comparing the 3 important groups in terms of patient numbers, you can see that according to statistical analysis, there was no difference between patients with restrictive thoracic disorders, neuromuscular disorders, and those with COPD in terms of an improvement in health-related quality of life, as specifically assessed by the SRI. However, again, and this was a multicentric trial, however, inspiratory settings were, I would say, at least high enough to improve spontaneous CO2 breathing. So, and this was also shown by the study that the CO2 was significantly and substantially improved, as pointed out before. So another interesting question is a physiological one, and this is, what about heart function? And this is the group from Italy. And first of all, what they very nicely did, and actually I was a little bit ashamed that we did not do this study. We should have done it before, but the Italians did a very, very nice job here, comparing spontaneous breathing, comparing low intensity NIV, comparing high intensity NIV with quite different approaches as displayed by our trials. So for high intensity NIV, pressures of 28 centimeters of water had been used, 18 centimeters of water for the low pressure setting, and a respiratory rate of 22 and a respiratory rate of 12 for the high and low intensity NIV respectively. So, and what they physiologically did, they put in balloon catheters and they looked at the esophageal pressures. And they nicely showed that the pressure generation by the patient was clearly reduced, while the inspiratory flow directed to the patient was increased, providing evidence that non-invasive ventilation was capable of resting the inspiratory muscles while simultaneously improving alveolar ventilation. And of course, physiologically, this was more evident when using high intensity NIV. At least over daytime, and this is a pure experimental setup, of course, but you can see that if you use high intensity in that approach, the esophageal pressures were more or less negligible. So this is pure passive ventilation. And this is when I say the diaphragm is sitting on the sulfur and completely relaxing. This is high intensity NIV in that approach. However, the original question actually, what is about what's happening with the cardiac output? And the authors also showed that the cardiac output is about to decrease in case of non-invasive ventilation being used. And unfortunately, I would say, however, this is scientific research. You can see that during high intensity NIV, there was a more substantially reduced cardiac output, and the researchers from that paper, they did conclude by saying that if you use high intensity NIV, it's physiologically absolutely reasonable. But however, in patients with pre-existing heart failure, we need to be cautious. Of course, I fully agree. However, this was a pure physiological study, and we do not know from this data how this was translated into clinical practice. My former co-worker, Mike Adria, he's now working in Aachen in Germany. He did a study on stable hypercapnic COPD patients, looking at cardiovascular biomarkers and also looking at inflammatory parameters when applying high intensity NIV. And of note, and I do not want to talk about inflammatory parameters, but just looking at the proBNP, there was a significant reduction in proBNP. At least there was no increase. So from laboratory findings, there was no evidence for a reduced cardiac output. And probably you know the Dutch group as well, Peter Wijkstra and Marieke Doberman. We work very closely to this group in Groningen. And Marieke spent a nearly 12-month period at our institution because she got a ERS grant. This is called long-term ERS fellowship grant, and she spent nearly a year at our institution. And we did a study on, again, high-intensity NIV with regard to the heart function. We did this together with a cardiologist in our department. This was, again, a randomized crossover trial. And now we did this, this clinical approach to what is about to happen in case of facing patients with pre-existing heart failure. Clinically, we did not use these higher pressures, 24 centimeters of water versus 15, and the backup rate 15 versus 12. And if you compare these two approaches, overall there was no difference in terms of the cardiac output. So even though we have this physiological remark from the Italian group, clinically we can say probably most patients would tolerate also higher pressures, even in case of pre-existing heart failure. However, there were very, very few patients having a deterioration in cardiac output. So our final recommendation in the end would be that a pre-existing heart failure would not serve as a clear contraindication for non-invasive ventilation and the high pressure or high intensity approach, but would definitely lead to a re-examination of the cardiac function and a very close collaboration with the cardiologists. So coming back to evidence, I think you are all familiar with the study we did in Germany, published now 5 years ago. And you can see again how actually ventilator settings are different in the studies. And even though this was a German study, ventilator settings were not as high as we originally described for high intensity NIV, which was 22 millimeters of mercury. However, there was a clear aim for the intervention, and this was predefined, as NIV was specifically aimed at reducing PaCO2 by at least 20% of the baseline values, or was aimed at achieving normal capnia. And in that definition, it was high intensity NIV, even though pressure settings were a little bit less. However, this was a study occurring in more than 30 centers. And of course, not all the centers were as familiar with the approach of high intensity as we did or did show in the past. However, there was a substantial benefit in terms of long-term survival, and the risk to die was reduced from 33% to 12%, ending up in a hazard ratio of 0.24, which is actually massive. As pointed out before, it's necessary also to show that not only survival is improved, and that this is particularly not at a cost of a reduced quality of life, as evidenced by the Australian shown, as critically discussed before. And in this study, again, the opposite turned out to be true, as the quality of life, as specifically measured by the SRI, was not changed in the low intent. It was not remained unchanged when only oxygen was given, with a small reduction in the end of the trial. But there was a significant improvement in quality of life when using high intensity NIV, and these improvements could be maintained during the subsequent year during which non-invasive ventilation has been continued. So we do have evidence for an improved survival, and with an additional improvement in health-related quality of life. So this was a clear positive study, and in that time everybody was quite positive, and the global thinking was actually every COPD patient should receive non-invasive ventilation. But what we have learned from the Dutch trial, that this is definitely not true, because more and more patients, and this is a crucial issue also of my presentation, is that more and more patients do receive non-invasive ventilation in the follow-up of acute respiratory failure. So patients show up with acute respiratory failure in the hospital. They do need acute NIV or even intubation. And the thinking is that patients are, and this is true, at high risk for readmission and re-exacerbation, and for becoming again dependent acutely on mechanical ventilation, and therefore one should start with non-invasive ventilation also for home treatment. So what the Dutch people did, and this is a huge study, 201 patients with COPD who had been treated with acute respiratory failure and the application of non-invasive ventilation. If these patients had prolonged hypercapnia, and it is important to also look at the definition, which was more than 48 hours after the termination of acute ventilatory support, if these patients had prolonged hypercapnia, they had been established on home NIV. And you can see that if you look at the primary outcome, the proportion of patients surviving, and the combined endpoint of readmission for respiratory cause or death, that there was no difference between the groups. In the end, the Dutch people also used quite high pressures in the approach of high intensity, and they nicely showed that also non-invasive ventilation in their cohort was capable of bringing down the CO2. And after they had been successful, NIV was capable of keeping CO2 at the reduced level. However, also in the standard group, there was a reduction in PCO2, indicating that not all the patients did require non-invasive ventilation in that approach. So this was, I wouldn't say a negative study, but it was a study stopping a pure positive view, saying that we need to be careful when deciding what patients really require non-invasive ventilation and what patients do not. And of course, I need to also show the British trial. And this trial is different compared to the Dutch one, even though the cohort is more or less the same one. Patients recovering from acute respiratory failure. Patients had been severely sick. The mean FEV1 was 0.6. The CO2 values were around 60 millimeters of mercury. And patients had, again, high intensity NIV, also provided by the British group here, 24 centimeters of water for the IPAP levels, and the backup rate of 14, so which is, of course, lower than we used in the past. However, there was a 12-month risk reduction of readmission or death with an absolute risk reduction of 17%. You can see that the median admission-free survival could be prolonged from 1.4 to 4.3 months. So providing evidence, if we give patients non-invasive ventilation following exacerbation. There is a cohort of patients benefiting from it, but the clear difference in regard to or in comparison to the Dutch study was that patients had persistently hypercapnic, saying that they had to be hypercapnic 2 weeks or even longer. So, and the Dutch group also very nicely did a subgroup or post-hoc analysis presented at the ERS conference in 2018, and showing similar results, but more clearly differentiated in regard to patients remaining hypercapnic or improving during the further course. So given in blue, you have the non-invasive ventilation group, and red is the group of patients receiving oxygen. And if you look at the patients who remained hypercapnic at 6 weeks, had the worst prognosis, and that you can also see that some of the patients not receiving non-invasive ventilation eventually did improve, even though they had been hypercapnic for at least 2 weeks. So saying that there is a further improvement over time, and then we need to go for further research in order to figure out what are the best candidates to be established on home NIV in the follow-up of acute respiratory failure. So, however, both the post-hoc analysis and the original trial has clearly taught us that we need to get in close collaboration with the outpatient clinics. So if we treat patients in the hospital, and if we discharge patients without raising question, what is the follow-up, then mistakes and drawbacks occur. So this is actually quite interesting to see also the evolution of the higher pressures. It's actually typical to also see that it's not true that you provide some new data and everybody's convinced. Typically it takes a decade or sometimes even longer if positive findings are really established in the international literature. This line here reflects the short term trials, and given in blue, this would reflect the long-term trials. And starting in the late 90s, you can see that the inspiratory pressures had already been increased to higher than 20, 25, even 30. This is data from our group. But later on, also other groups started to use the same settings. And in regard to the long-term trials, producing or providing outcome, the first trials were purely negative, but also purely used lower settings. And with the beginning of this decade, inspiratory pressures are also reportedly maximally increased also in the long-term outcome trials, just to present the evolution of how this behaved in the literature. So one of the final issues now is how can we proceed with patients in the outpatient setting. And I know there are some ongoing studies also looking at the possibility to also establish patients on long-term NIV in the outpatient setting, so not in the center, not in the hospital, maybe even in the home environment for economic reasons, but also for practical reasons. But first of all, we should also look at the feasibility to go for a control visit outside the hospital, or at least in outpatients, which might occur in an outpatient clinic, which is very closely related to the mechanical ventilation center. And this is a study we did very recently, looking at patients already established on non-invasive ventilation. What we did in advance, we did define major criteria, most importantly related to hypercapnia, to acidosis, and the clinical picture of exacerbation. And if these patients came in for an outpatient control, we suddenly went for acute hospitalization. And this was also true if patients had two minor criteria based on PaC2 values, based on mask problems or adherence problems or whatever. If we had two of the minor criteria, we also went for hospitalization, not immediately, but during the upcoming couple of days or weeks. But what I actually like to show you is, and this is interesting to remark, that even in our setting where we very frequently establish patients on non-invasive ventilation electively, only about 1/3 of the patients had real chronic elective NIV. So the reality today is that most of the patients do receive non-invasive ventilation in the follow-up of acute respiratory failure. And this was also shown by this trial. And it is also shown that in regard to 130 cases, 9 cases did not require further non-invasive ventilation. So what I'm saying in regard to that study is that we need, okay, I'm fine. And what I'm saying is that we need to make sure that really all patients who have classical indication criteria should also be offered non-invasive ventilation. But we should also be very careful in order to avoid an oversupply. So many patients rapidly receive non-invasive ventilation after acute exacerbation, but they have maybe no need to further continue on mechanical ventilation. This was also shown in that trial. And we have also shown that in regard to the remaining cases, that about 2/3 of patients could stay as an outpatient, and 1/3 of patients required hospitalization for further improving non-invasive ventilation, for improving adherence, for solving technical problems or whatever. Most patients spend only 2 to 3 days in hospital, even though very few patients did require a longer period of time in hospital. And typically, these are patients who had not been sufficiently established on high intensity NIV during the first period in hospital, and who required a further follow-up to get patients better acclimatized in the hospital setting. So in regard to the evidence we got so far, if I could summarize the evidence, we have learned from the Australian trial that actually long-term non-invasive ventilation using the low intensity approach is absolutely not capable of improving the physiology, does produce deteriorations in quality of life, and may only be very insufficient in improving long-term survival. What we have learned from the Dutch trial is that not all patients requiring acute NIV in the hospital would subsequently need long-term NIV in the home environment. And we have learned from the Köln trial, from the German trial, that in a pure chronic setting, it's clear that long-term non-invasive ventilation using higher pressures aimed at physiologically improving the PaCO2 values, that this approach is capable of improving the physiology, is capable of improving quality of life, and also capable of improving long-term survival. But last but not least, we have learned from the British group that indeed there is room for also applying non-invasive ventilation in the post-acute phase, but this is only true if patients have persistent hypercapnic respiratory failure, and persistent hypercapnia means at least 2 weeks after the termination of acute NIV or acute mechanical ventilation in hospital. And as pointed out before, this issue needs to be further elucidated in the future. So just to also give an impression of our guidelines, we have done this, our German guidelines in 2010, and we did a revision in 2017. This was, of course, written in German, but the journal Respiration was very kind in giving us the opportunity to also provide a full-length translation into English. And because it's a very, very long manuscript, longer than 30 pages per issue, they did provide 2 different parts for the 2017 edition. And I think you have free access, so it's probably very easy to have a glance at our guidelines. And just to summarize my talk for today is that, and we gave this clear recommendation in our guidelines, that we have actually 2 different groups of COPD patients potentially benefiting from non-invasive ventilation. And in my personal perspective, it's absolutely necessary to clearly distinguish between these two groups and not to mix up these two groups. Even though we need to get more data on these two groups and on the difference, my personal thinking is that both the prognosis but also technical things are completely different in regard to these groups, and the indication criteria, of course, are different. And coming back to the evidence in regard to these two groups, we have first of all the chronic condition where patients are severely symptomatic, even though medication did receive, rehabilitation did receive oxygen treatment. If they have a classical indication criteria as evidenced by CO2 values, then go for NIV. And I think all of these patients should be offered NIV so far. The completely different group is persistent hypercapnia following acute exacerbation. Please, we need to avoid oversupply, but we need to get in very close contact with the doctors caring for patients in the outpatient setting. And then it's clear that if we have persistent hypercapnia, we can reduce rehospitalizations and death. Therefore, this is a second clear indication for non-invasive ventilation to be used in patients with chronic obstructive pulmonary disease. And last but not least, non-invasive ventilation does not make sense if we would aim non-invasive ventilation at physiologically improved gas exchange, namely PaCO2. And for that purpose, we need at least to go for higher pressures. The discussion on higher respiratory rates needs to be continued. Personally, and my experiences, that many patients, and I have pointed out this before, would also benefit subjectively when they can relax sitting in a sofa, but this needs to be further consideration in the future. So thank you so far for your attention. And by the way, this is Cologne. We're just sitting here, by the way, very close to the River Rhine, which is more or less here. This is the Kölner Dome, the big cathedral. This is the more modern part. And by the way, I live here in the second row in the near of the Rhine. Thank you very much. I will be happy to serve with your questions. There was no, technically, it was very difficult for non-invasive ventilation with the home care systems to apply a PEEP. So for practical reasons, we never used one. So the first 5 to 10 years, we never used a PEEP, never. So zero was, the PEEP was set to 0. And non-invasive ventilation was reportedly quite successful. So if you look at our initial trials, we never used PEEP values. Later on, the newer BPAP devices, you have to use a BEEP of at least 2 to 4 centimeters of water. And of course, they say physiological rationale to also use a PEEP level. And this is true for patients with dynamic hyperinflation. And the second is true for patients with obesity. So these are 2 different scenarios. And the answer actually is that most patients do not need a real high PEEP for the dynamic hyperinflation issue. Because if you and of course we need to balance this absolutely well against the inspiratory pressures, because if the pressures are too high, of course you have dynamic hyperinflation. But then to use a PEEP in order to counterbalance dynamic hyperinflation does not work. So then we need definitely, first of all, we need to reduce the pressure settings, first of all. The second issue is, what about dynamic hyperinflation, even or despite having a increased or not severely increased inspiratory pressure? I don't know. We have no data. The real answer is we do not know if it's really required. Sometimes we do it just because, yeah, we got used to it or whatever, but we have no clear studies showing that it is needed. However, we do have a problem in terms of facing the need to also increase the IPAP if the EPAP is increased, because the driving pressure is reduced if you do not increase the IPAP as well, in case of EPAP being increased. right? So we need to be very careful. And the third issue is, what about dynamic hyperinflation and EPAP setting during physical activity? This is a complete different issue. And of course, if patients have an increased respiratory rate occurring during physical activity, then it physiologically would make sense to also apply a PEEP or an EPAP level. But I do not know studies clearly providing evidence on how to set the level in a certain scenario. So do it clinically, do it practically, and avoid automatically using higher PEEP levels if not really needed. One question is, are there any evidence for ventilating COPD with stable daytime normal capnia, but many exacerbations? Normal capnia? No, definitely not. If the patient is not hypercapnia, there's no evidence for non-invasive ventilation in a routine manner. Of course, if you have an individual patient, and if this patient is normal capnia all day long, and if you have severe exacerbations with a need to go for acute non-invasive ventilation because you need to treat respiratory acidosis, in an individual case you can try, but we don't have evidence, and that was the question, right? Another question would be, would you ventilate a COPD with only nocturnal hypercapnic? I don't know if it's feasible if we can go back to our recommendations for guidelines. Is that feasible? Yes. If you take a close look at the indication criteria, even though we only have sparse evidence, of course, and this is also a mix of what we have learned from the trials and also expert opinion. However, if the daytime PCO2 is between 45 and 50, but there's a further increase in transcutaneous CO2 overnight, then we would also see an indication. In contrast, if patients have a PCO2 over daytime which is less than 45, so if the patient is purely normal capnic, then we wouldn't go for nocturnal measurements, as it is very unlikely that this patient would eventually experience a huge increase in CO2 overnight. I mean, if this is related to obesity and if patients would have a different reason for why nocturnal hypercapnic respiratory failure could occur, this is a different question, a different scenario. Then we would behave differently and we would measure transcutaneously or would measure transcutaneously. But in normal capnic patients, we would definitely not go for non-invasive ventilation. Yes? Another question? Team Finland. You use CO2 levels to adjust NIV. What about PO2 levels? No, we just go for COPD, as non-invasive ventilation or mechanical ventilation overall is physiologically aimed at improving alveolar ventilation. And alveolar ventilation is at best evidenced by COPD, CO2 in a clinical scenario. Interestingly, and the question is in so far interesting as you are right, there are some patients with predominant hypoventilation saying that if you properly treat hypercapnic respiratory failure, these patients will eventually not require long-term oxygen treatment. However, most patients also established on non-invasive ventilation would also additionally require long-term oxygen treatment. And the indication for long-term oxygen treatment is, even though we do not have data, according to all the guidelines we have, is evidence and based on the recommendations we have for long-term oxygen treatment in COPD patients also without non-invasive ventilation. So second question, could you please remind us what are the GOLD 19 and or NICE guidelines for the management? The GOLD guidelines, this is a difficult question. I'm a little bit ashamed because I should honestly say what my thinking is. And my thinking is that in the GOLD guidelines, the issue of non-invasive ventilation in COPD is not appropriately addressed. So I would not address the gold guidelines in regard to the question if non-invasive ventilation is useful in COPD patients or not. It's only one paragraph. Many studies are not cited, and the conclusion is crucial. You are right. We should address this also internationally. We should write a letter or something. But practically, you are advised to directly go to the guidelines specifically focusing on non-invasive ventilation. About 10% of COPD patients have OSA. EPAP at 4 would not be enough, of course. That's what I'm saying. An EPAP is actually not required in pure COPD patients. If you have a comorbidity, such as sleep apnea or obesity hyperventilation or any other form of sleep-related hyperventilation, we need to consider an EPAP. And if I did some, if you got a different experience from what I said before, of course you're absolutely right. Then we need to go for an EPAP level. Okay. How you would be sure that apneas are treated clinically, and in case of any question, we need to go for polysomnography, and we also do it a lot of time. So if there's a patient maximally benefiting with non-invasive ventilation, symptoms are improved, sleep gases are improved, probably I would personally not go for polysomnography. But if patients would not tolerate non-invasive ventilation overnight, if patients would remain on high CO2 levels, or if patients would indicate in the morning that they are not refreshed, they have they have morning headaches or typical symptoms of sleep disturbances, of course we would go for polysomnography, and we would make sure that also obstructive events are sufficiently treated. What are your thoughts about rise time when it comes to, yes, rise time? If we go for respiratory rates approaching 18, 20, 21 or something, then you can imagine that the time for a single inspiration or for a single expiration is quite short. The first aim is to maximally avoid dynamic hyperinflation. So you need at least an I to E ratio of 1 to 2. And therefore the inspiratory time is around 0.8 or 0.9 seconds. And if that inspiratory time is quite short, we need to have a very, very short rise time in order to guarantee that pressure is translated in volume. And the second issue, that COPD patients subjectively require a very, very high rise time. And it might become true that even though patients would tolerate NIV and they could also trigger the ventilator, a very, very short rise time could produce discomfort or subjective feelings, saying like, you know, that patients would not tolerate NIV. So make sure that the rise time is very, very quick. The inspiratory time is short to allow at least expiration in the manner that hyperinflation is avoided in regard to the respiratory frequency you have chosen.
We have some discussions about backup frequency, and this is also about the patient. They go down and they lie on the backup frequency and they let the ventilator run their breathing. Is that a problem too?
What do you mean? If the patient is purely relaxing?
Yeah.
Wow.
Should you push the patient to have their own breathing?
Yeah.
Or is it okay that they lie on the backup frequency?
If you are exhausted, and if you are very, very exhausted, imagine the worst scenario. If you go home, what would you do? You would relax yourself, lying on the sofa. So that's the best thing you could do with the diaphragm, lying on the sofa. So if the machine could do everything, and the machine would also, so we won't face any trigger problems in case of the machine providing all the respiratory efforts. We have no respiratory effort for triggering the ventilator, so we have less work of breathing, and the patient is maximally relaxed. So actually, that is the best way. It does not. It's not feasible in all the patients, as dynamic hyperinflation can occur. And the second issue. Sorry, I have a second voice again with your move. Again, okay. And the second thing is that, of course, we do have the discussion with ventilator-induced diaphragmatic dysfunction. We know that a couple of hours can produce harm on the diaphragm. And that is the reason for why people keep thinking that actually non-invasive ventilation should not be given in a controlled form. But I would remind all of us that ventilator-induced diaphragmatic dysfunction occurring on the ICU or in the operation theater is a completely different scenario. Patients are typically deeply sedated. Patients are relaxed. Patients have inflammation. They have sepsis or whatever. So all these conditions are prone to produce a severe harm on the tissues, also including the muscles and the respiratory muscles. And it's also true that if you go for controlled ventilation, patients are typically not 100% controlled ventilation for 8 hours in the row, you know. It's rather the percentage of breath not triggered by the ventilator, which is increased by increasing the respiratory rate. So, of course, I have never looked at a histological pattern in diaphragms of COPD patients having received controlled NIV overnight. But I don't believe, my clear personal belief is that there's no harm produced by controlled ventilation if most of the respiratory rates are given by the ventilator and if the patient is allowed to fully relax. So go for it and try it.
Okay. Yeah. But there is sometimes there's sometimes a fear that the patient will be too dependent on the ventilator and use it 24 hours.
Yes.
Is that a problem?
I mean, of course, if the disease proceeds, or if you have a progression of the disease, of course, much more time might become necessary for spending on the ventilator. But actually, we do not have these problems with a dependency, even though it's clear that if you start non-invasive ventilation, of course, the patient will use the non-invasive ventilator for the rest of their lives. So, of course, they are more or less dependent, but it's not true that if you go for more aggressive forms of ventilation, that they're more dependent in terms of more hours are required on the ventilator. I personally guess that the opposite eventually would turn out to be true, that if you apply more sufficient ventilation, if you have higher pressures and high respiratory rates, less time on the ventilator is eventually required to achieve good and acceptable physiological results. Have you ever used mouthpiece ventilation for the COPD patients? Yes, in very, very, very single patients, but mouthpiece ventilation is actually specifically dedicated for patients having a duration of non-invasive ventilation for more than 12, 14, 15, or 20 hours, or even 24 hours. And the typical group of patients are neuromuscular patients, so Duchenne patients or other neuromuscular disorders. I personally know some individual COPD patients who use non-invasive ventilation for more than 12, 15, or 14 hours. And I remember one or two patients also using mouthpiece ventilation, but this is very, very rarely used in the cohort of COPD. And of course, it wouldn't work overnight. So if a significant amount of daytime ventilation is required to control nocturnal or daytime hyperventilation, then you can try it. But it's not regularly used.
They don't hear me, but maybe you can repeat. So what are your thoughts on the Borrell studies that you can prevent? You know, repeat the question.
The question was, what are my thoughts on the Borrell study? I have just shown this. Actually, personally, I feel that this is an important short report. This is not a full study. This was published as a short report in thorax, so preliminary data. And you can see 64 patients were included and only 21 exacerbations were detected. But it's interesting to see that built-in software things and issues could become an important tool to also guide the patient. And that this is how to maybe when it's time to go to the hospital or to the center, or how maybe patients could increase the ventilation time, or is required to add some medication or whatever. So it's nicely shown that the respiratory rate, and this is actually the most important issue, that the respiratory rate was around 10 to 14 days preceding exacerbation. And the 5 days before, the respiratory rate was already 18, so it was increased. And when the exacerbation, the day of the exacerbation, there was again a rapid increase in the respiratory rate. So if the patient has a possibility to monitor for this type of monitoring, this is absolutely interesting. I wouldn't say that it can be globally used, that in every patient, each increase in respiratory rate would eventually end up in a severe exacerbation. And we also need to learn what an exacerbation is and how an exacerbation is handled in these patients. Is it necessary to go to hospital? Is it necessary to just start steroids? Is it necessary just to expand the duration of mechanical ventilation as used overnight and daytime? We don't know. So we need to get more practical data and how to translate these findings into clinical practice. However, the study very nicely showed the potential of telemonitoring, and I'm quite confident that we will learn a lot of more things in the next 5 to 10 years about telemonitoring. How is the cooperation between the ward and the outpatient clinic to make sure that the right patient is treated with home mechanical ventilation? So I'm really grateful for this question, because maybe it's one of the most important questions we have to face today. And surely it's absolutely dependent on the system you work in. In the Netherlands, for example, it's quite easy. They have these outpatient settings within the hospital. In Germany, we don't have. And I can only explain how the scenario in Germany is. And honestly speaking, it's worse. It's worse compared to most of the countries I get, at least in terms of that scenario. Because what we do have to face in Germany is that we have a strict, so outpatient and inpatient treatments are very strictly they have two different scenarios actually we have. So insurances, hospitals, they only deal with one issue, not with the two issues. So therefore we need to contact our outpatient carers, I mean the physicians, the general practitioner, the pulmonologist, but we have no clear rules on how to proceed with these patients, unfortunately. Saying that if there's a patient recovering from acute NIV, and if we are not sure, should we proceed with non-invasive ventilation in the home? And we might say, no, it's not necessary so far, but we need to have a follow-up, then we have no organization for that. Because in Germany, in the vast majority of the hospitals, we are not allowed to care for our patients. This is the reality. So it's actually a pity. Yeah. So try to do your best, and also in order to get into contact with the two different systems. This is my advice, yes. I see different forms of phenotypes of COPD when I ventilate. Some can last a whole day from their night, and others need NIV in the middle of the day to keep normal capnia and normal pH. Would you ventilate the pH differently at night, or just mainly tell them to use NIV in the middle of the day? Also, a very good question. Thank you very much. The question addresses the issue of how could we eventually increase mechanical ventilation. Is it just in spending more days more hours per day on the ventilator, or would we go for an increase in the settings? I would go for both. If PCO2 values are not in the normal range overnight, I would definitely try to do my very best in order to improve alveolar ventilation overnight. And the primary aim is to get down the bicarbonate levels, because the CO2 is very is less stable than the bicarbonate. And we should also be very, very careful, as these patients requiring also daytime mechanical ventilation are the more hypercapnic ones. And hypercapnia typically produces peripheral edema, which is related to CO2-related vasodilation. And what patients typically receive as diuretics. So in the assumption that they have cor pulmonale or coexisting heart failure, even though that might be the case, loop diuretics are too frequently prescribed in COPD patients with hypercapnia. Because if you describe loop diuretics, then you have you produce metabolic alkalosis, so the bicarbonate is increased, and this would translate an increase in CO2, and then for the control of CO2 overnight, you have to go for daytime application of non-invasive ventilation. So this is a very difficult question and a very sophisticated question, and you need to globally look at the patient. That is, to improve the settings overnight. If this is okay, then go for an additional duration of non-invasive ventilation during daytime. And third, avoid loop diuretics as much as possible and make sure that bicarbonates are reduced and not increased because of medication. So 3 steps actually. In an acute NIV treatment where the patient has a very high respiratory rate, 30, for example, would you increase backup rate very close to that right? Thank you very much for this also very important and interesting question. So just to summarize the difference between acute and the chronic setting, it's absolutely clear that high intensity NIV is only feasible in the chronic setting. High intensity NIV and the acute setting have nothing to do with each other. You know, in a patient with a high respiratory rate, in the clinical scenario of acute exacerbation, the aim is to reduce the respiratory rate. This can be achieved by the application of mechanical ventilation, by medication, oxygen, also by providing non-invasive ventilation. The clear aim is to reduce the respiratory rate. I wouldn't go for high intensity NIV, and definitely you need to avoid high respiratory rates, because the likelihood to produce further dynamic hyperventilation is massive. And sometimes, even during pressure support ventilation in the acute setting, you are not able to see the real respiratory rate as produced by the patient, as many of these patients have trigger problems. And also the ventilator curves as displayed on the ventilator in the acute respirator do not show the whole scenario occurring. If you go for NAVA, neurally adjusted ventilator assist, you are sometimes very easily able to see the real respiratory rate, and then the respiratory rate is typically massively higher. So the goal must be to reduce the rate and not to increase the rate. And in the acute setting, the settings must be low. The expiration time must be very, very long. Use a PEEP and don't go for high pressures and not for high respiratory rates. Continuing previous question, would you ever change trigger settings instead? Regarding which one? The acute? Yes, of course. I would try to change the settings, even though we have no tools sufficiently indicating that we are on the right way. Sometimes, and this is particularly true for patients also receiving sedative drugs, you cannot always see the real respiratory rate, and we do not know if the patient is sufficiently triggering the ventilator. Then you have to play with the knob and see if it works. However, if the flow curve shows severe or massive dynamic hyperinflation, you need to also supply and provide all the other techniques to avoid dynamic hyperinflation, to reduce the pressures, to reduce the rates, and also to provide the correct medication. And if you have the techniques, put in the esophageal balloon measuring the real respiratory drive as derived from the diaphragmatic signal as provided by the system, also giving us the possibility to apply the nervous system. So with the nervous sound, you can also see the respiratory rate much more sufficiently. I should also have included some acute slides, actually, right? We will do it the next time to also address the bridge between acute and chronic setting, also make sure what the differences are. It's a clear difference. It's necessary to again point out that acute and chronic NIV is completely different.
Thank you and have a good night.
Big pleasure. Thank you so much for joining.